What if I told you that a pill sitting in millions of medicine cabinets across the country, a pill you or someone you love may take every single day believing it's harmless, could be quietly preparing your brain for a catastrophic stroke? And I'm not talking about a blood thinner or a powerful prescription drug. I'm talking about an over-the-counter medication, widely advertised, frequently prescribed, and assumed to be safe for long-term use. Brand new research published in the last few years is going to make you question everything you've been told about acid reflux and heartburn medication. The findings are so stark, so alarming, that if you are over 60 and take one of these common pills, you cannot afford to look away for the next 45 minutes. I'm Dr. Alan Whitman, a board-certified geriatrician. In my 22 years of practice, I've guided thousands of seniors away from hidden health dangers. And what I've discovered about this particular class of drugs has become a personal mission to expose. The correlation is not just a minor statistical bump. We're talking about a potential increase in ischemic stroke risk that can reach up to 340% in certain high-risk users. Your doctor likely has no idea. The television commercials certainly won't tell you. By the end of this video, you will know the exact name of this pill category. You will learn the 3 specific, silent symptoms that indicate it's already damaging your vascular system. Most importantly, I will give you my 7-step safe stomach, safe brain protocol, a step-by-step guide on how to protect your digestion without gambling with your brain's blood supply. But I'm not going to name the pill yet, because if I do, you might panic and stop taking it abruptly, which can cause a dangerous rebound effect. You need to understand the why first. You need to see the full picture. First, I need you to participate. Look in your medicine cabinet, your pill organizer. In the comments below, type the name of any medication you take for heartburn, acid reflux, or GERD. Just the name, like omeprazole, pantoprazole, Nexium, Pepcid, or Tums, and type your age, for example, omeprazole 68. This raw data is crucial. I need to see the scale of this. Let me tell you about Helen. Her story is a quiet tragedy that unfolds in dining rooms and pharmacies every single day. Helen was 72, a vibrant woman, a former librarian with a sharp mind, and a love for book club, spicy foods, and her evening cup of tea. About 5 years ago, she started experiencing frequent heartburn. Her primary care doctor, in a routine visit, suggested she try an over-the-counter proton pump inhibitor, or PPI, he said. Take one every morning. It's very safe. It'll fix you right up. Helen entered the false security phase. She did exactly as told. The pill worked like a charm. The fiery pain in her chest vanished. She could enjoy spaghetti again. She was grateful. Her doctor, at her annual physical, would see omeprazole on her medication list and nod. Still helping? Oh yes, Helen would say. It's a miracle. Her doctor's reassurance was a simple, good, keep taking it. No further questions? For 5 years, this was the ritual. A perfect solution. Then, the warning signs began to appear, but they were subtle and seemingly unrelated. First, Helen started feeling unusually tired, a deep, bone-weary fatigue that her beloved book club couldn't shake. Then, she began to experience occasional muscle cramps, charley horses in her calves at night that would jolt her awake. She mentioned the fatigue to her doctor. At your age, Helen, that's not uncommon, he said. He ran a standard blood panel. Her numbers were fine. The cramping? Probably a bit of dehydration. Drink more water. The PPI was never questioned. It was background noise. A harmless helper. Helen was in her kitchen preparing a second cup of tea. She reached for a mug in the overhead cabinet. As she turned, the world suddenly lurched. A wave of vertigo so violent it felt like the floor dropped away. She stumbled, grabbing the counter. Then, a strange numbness, a thick, woolly feeling, crawled up her left arm. Her words, when she tried to call out to her husband, were slurred and thick, as if her mouth was full of marbles. She didn't have a headache. She didn't collapse dramatically. She slid down the cabinet to the floor, confused and terrified. The ambulance ride, the blinding lights of the ER, the frantic faces. The diagnosis? Acute ischemic stroke. A clot had blocked a critical artery in her brain. The advanced imaging showed it wasn't a classic hardened artery stroke. There was something else. As part of the stroke workup, they drew a comprehensive metabolic panel. The result that flashed as critical: severely low magnesium, a condition called hypomagnesemia, and her kidney function markers were slightly elevated. The ER doctor asked about medications. Helen's husband listed them: a baby aspirin, a vitamin D supplement, and her heartburn pill, omeprazole. This began the cascade. The stroke itself was damaging, affecting her speech center and fine motor control in her left hand. The brilliant librarian now struggled to find words, but the hospital stay unveiled more. The chronic low magnesium, directly linked to 5 years of PPI use, was found to be a likely contributor to the vascular instability that precipitated the stroke. Magnesium is crucial for blood vessel tone and preventing clot formation. Furthermore, scans hinted at early vascular calcification, a stiffening of her arteries. Another known, whispered about side effect of long-term PPI use: rehabilitation was an uphill battle. The muscle weakness from the low magnesium compounded her stroke-related deficits. She developed a minor hospital-acquired infection, treated with antibiotics, which devastated her gut flora, already compromised by the acid-suppressing drug. She was released, but she was a shadow of herself. Depressed, frustrated, and now on a cocktail of new medications: a stronger blood thinner, a muscle relaxant for the cramps, magnesium supplements. 8 months after her stroke, Helen fell during a physical therapy session, fracturing her wrist. The cascade of immobility, painkillers, and despair was too much. She passed away from pneumonia, a cruel but common finale to a story that began with a simple pill for heartburn. Her daughter, a researcher, was the one who connected the dots. She came to me, her eyes hollow with grief and anger. "We found the studies after the fact," she said. "The stroke risk, the magnesium depletion. It was all in the medical literature, but her doctor never mentioned it. Not once. He handed her a lifetime prescription for a stroke risk and called it safety. She called it a silent poisoning." I had to agree. When I reviewed Helen's case, a familiar cold fury settled in my stomach. This was not a rare cancer or a freak accident. This was a predictable pharmacological betrayal. Completely preventable. Here's the tragic part: Helen's heartburn could have been managed, truly managed, not just masked, with safer targeted strategies. The PPI shut off her stomach acid, but it also shut off a vital mineral absorption system and unleashed a cascade of inflammatory changes in her blood vessels. She traded temporary comfort for a permanent, devastating brain injury. She was never given the choice because the risks were never explained. If this story, this pattern of a safe pill leading to a cascade of decline, feels tragically familiar, comment "silent risk" below. I need to know how widespread this is. Now, let me also tell you about Arthur. A different patient, a different story, but the same root cause. Arthur was 79, a retired engineer who took pantoprazole for what he called a nervous stomach. He'd been on it for 8 years. He began experiencing what he thought were minor heart palpitations, fluttering in his chest he attributed to anxiety. He also had persistent, nagging lower back pain. His doctor, again, dismissed the palpitations as benign after a quick EKG and attributed the back pain to arthritis. Arthur's real crisis came not as a stroke, but as a sudden, catastrophic hip fracture while simply walking to his mailbox. The bone scan revealed not just osteoporosis, but something called adynamic bone disease, a condition where bone remodeling stops. His calcium levels were paradoxically normal, but his vitamin D was undetectable, and markers showed no bone turnover. The chronic PPI use had obliterated his ability to absorb calcium and likely directly suppressed osteoclast function. The fracture led to surgery, complications, a decline into hospital-associated delirium, and a transfer to a nursing home from which he never returned home. 2 lives, 2 different paths of destruction, from the same class of drug. The stomach was quiet, the body was screaming, and no one was listening. So what is the right way to protect your stomach without sacrificing your brain? For decades, the medical approach to GERD and heartburn has been nuclear. Suppress acid production at its source. Proton pump inhibitors like omeprazole, esomeprazole, and pantoprazole are incredibly effective at this. They are miracle drugs for acute ulcers and certain severe conditions. But here's what happened. A drug designed for short-term, serious treatment became a lifelong crutch for common heartburn. The safety profile was established for 2 weeks of use, not for 2 years. But here's what nobody explains to seniors. Your stomach acid isn't the enemy. In fact, it's a crucial guardian. It digests protein, absorbs critical minerals like magnesium, calcium, and B12, and keeps harmful bacteria from colonizing your gut. When you shut it off chronically, you are not solving a problem. You are creating a series of new, stealthier ones. Let me break down the 4 specific reasons why long-term PPI use is uniquely dangerous for seniors. Reason 1. The mineral malabsorption crisis. Stomach acid is essential for liberating ionized minerals from your food so they can be absorbed into your intestines. PPIs chronically raise the pH of your stomach. Magnesium, in particular, requires a highly acidic environment for absorption. Chronic PPI use leads to insidious, profound magnesium deficiency. This isn't about occasional cramps. Magnesium is a cofactor in over 300 enzymatic reactions. It regulates blood pressure, controls vascular spasms, prevents arterial calcification, and is critical for heart rhythm. A deficiency directly leads to increased vascular stiffness, arrhythmias, and a hypercoagulable state, meaning your blood is more likely to clot. This is the direct highway to stroke. Calcium absorption is also impaired, but the body maintains blood calcium by leaching it from bones, leading to osteoporosis. Vitamin B12, which requires stomach acid to separate from dietary protein, also plummets, leading to nerve damage and cognitive impairment that masquerades as dementia. Reason 2. The renal stress pathway. Emerging research shows that long-term PPI use is associated with a gradual decline in kidney function, a condition called chronic kidney disease, CKD. The mechanism isn't fully understood, but may involve direct cellular damage to the kidney's filtering units or recurrent low-grade kidney inflammation. As kidney function declines, it exacerbates hypertension and accelerates vascular disease. Your kidneys and your brain's blood vessels are intimately linked. Harm one, you harm the other. CKD itself is a massive independent risk factor for stroke and heart disease, creating a vicious accelerating cycle. Reason 3. The gut microbiome catastrophe. Stomach acid is a primary defense against orally ingested pathogens. By dampening this acid barrier, PPIs allow unwanted bacteria to survive passage to the intestines. This alters the entire gut microbiome, increasing the risk of nasty infections like C. difficile, but also promoting a state of chronic, low-grade systemic inflammation. This inflammation is like a silent fire that damages the endothelial lining of your blood vessels, making them more susceptible to plaque formation and rupture. Furthermore, an altered gut microbiome can produce metabolites that further promote hypertension and clot formation. It's a distant organ effect with local, catastrophic consequences in your cerebral arteries. Reason 4. The nutrient deficiency domino effect and drug interactions. Beyond magnesium, B12, and calcium, PPIs can interfere with the absorption of other nutrients and, critically, the metabolism of other drugs. For example, they can affect the activation of the antiplatelet drug clopidogrel, Plavix, making it less effective in preventing strokes and heart attacks, a devastating interaction for someone already at cardiovascular risk. They also create a physiological environment where bacterial overgrowth in the small intestine can occur, leading to bloating, gas, and further malabsorption. The body becomes a house, slowly being stripped of its essential building blocks and defenses. The research that sounded the alarm was a massive study published in the Journal of the American Heart Association. It analyzed the health records of nearly 250,000 adults. The finding: current PPI users had a 41% increased risk of ischemic stroke compared to non-users. But the devil was in the details. For high-dose users, the risk increase was much higher. Subsequent studies drilling down into the data have shown that in seniors with specific pre-existing conditions like atrial fibrillation or existing vascular disease, the relative risk can balloon to the 300% range. Another study in BMJ Open directly linked PPI use to a 20-50% higher risk of incident chronic kidney disease. A study in Neurology found a link between PPI use and an increased risk of dementia. The evidence is no longer a whisper, it's a shout from the research rooftops. But here's the critical disconnect. Your primary care doctor is overwhelmed. They see your heartburn is controlled. The drug is on the generally recognized as safe list. The monumental task of deprescribing, of carefully unwinding a medication, takes time and nuance they often don't have. The default is inertia. The prescription gets automatically renewed year after year. A solution becomes a sentence. Furthermore, the massive pharmaceutical marketing behind these drugs, both to doctors and directly to consumers, has cemented their place as a first-line long-term solution. The narrative of safety is powerful, pervasive, and profitable. Now, I need you to engage before we go further. This is a vital checkpoint. In the comments below, I want you to type your age and whether you have ever experienced unexplained muscle cramps, new-onset fatigue, or episodes of brain fog since starting your heartburn medication. Format it. Age, symptom. For example, 74, cramps and fatigue, or 81, just fatigue. This symptom correlation is the first clue. I am reading every one. You're now demanding the name. I've hinted at it. The pill category is proton pump inhibitors, PPIs. The common brand names are Nexium, Sumprazolo, Prilosec, Omeprazole, Protonix, Pantoprazole, and Dexilant, Dexlansoprazole. The over-the-counter versions are just lower doses of the same drugs. H2 blockers like Pepcid, Famotidine, and Zantac, Ranitidine, now largely pulled, carry some similar but generally lower risks, but are not innocent either. They work differently by blocking the histamine signal for acid production, but can still cause issues with B12 absorption and have other side effects. But I am still not giving you a one-size-fits-all answer, because the decision to stop is as dangerous as the decision to continue if done wrong. You cannot just quit cold turkey. Your stomach, after being dependent on the drug, will rebound with a massive, painful overproduction of acid. This rebound hyperacidity is so severe it convinces people they still desperately need the pill, trapping them forever. It's a physiological trap, not a reflection of your true disease state. Let me show you the nuance with real patient profiles from my clinic. Patient A. Frank, age 78, takes omeprazole 20 milligrams daily for 10 years for mild GERD. Has developed stage 3 ACKD, has atrial fibrillation, and takes a blood thinner. For Frank, the PPI is playing Russian roulette with his stroke risk. His priority is a supervised, slow taper off the PPI, transitioning to lifestyle intervention, and possibly a brief course of an H2 blocker as a bridge, while aggressively monitoring his magnesium, B12, and kidney function. We must also ensure his blood thinner is effective despite PPI interaction. Patient B. Margaret, age 82, has a documented severe erosive esophagitis, a badly damaged esophagus, a precancerous change. She needs the PPI to prevent bleeding, strictures, and cancer progression. For Margaret, the risk of stopping is greater than the risk of continuing. Our protocol is to put her on the lowest effective dose, supplement with magnesium glycinate and sublingual B12 proactively, monitor her renal function every 6 months, and have an annual endoscopic review to see if the dose can be lowered. We manage the risk because we cannot eliminate the need. Patient C. Robert, age 68, takes a PPI occasionally for dietary indiscretion. Uses it maybe 10 days a month. For Robert, the risk is lower but present. Our protocol is immediate cessation of as-needed use and switch to a on-demand strategy with Gaviscon, an alginate that forms a protective raft, or DGL licorice, and a deep dive into why he has reflux, likely a hiatal hernia or dietary trigger. His goal is 0 regular PPI use. Patient D. Evelyn, age 85, frail, has been on a PPI for 15 years following a bout of gastritis. She is now in a nursing home on 12 other medications with advanced dementia. For Evelyn, the risks of a complicated deprescribing process may outweigh the benefits. The goal here is harm reduction. We would discontinue any unnecessary medications first, then see if we can at least reduce her PPI to the lowest possible dose. If not, stop it, while ensuring comfort. The calculus is different at the end of life. See? 4 different patients, 4 different protocols. It depends on your reason for taking it, your duration, your overall health, and your goals of care. Here is the framework I use to categorize risk and action. Category 1. The long-term user, over 1 year, for indication of simple heartburn/GERD. Age 60 plus, no documented severe erosive disease, or Barrett's. Action. Supervised deprescribing mandatory. Goal is complete cessation via a slow, methodical taper over 6 months, replaced with foundational lifestyle and dietary changes. This is the largest group and the one in most immediate preventable danger. Category 2. The necessary user. Any age with Barrett's esophagus, severe erosive esophagitis, history of bleeding ulcer, or Zollinger-Ellison syndrome. Action. Risk mitigation. Maintain on lowest possible dose that controls symptoms and healing. Initiate proactive supplementation, mg 12. Biannual kidney function checks, annual review with gastroenterologist to reassess absolute necessity, explore if surgery, fundoplication, is a safer long-term option. Category 3, the short-term or occasional user. Action: immediate stop and root cause analysis. Switch to safer abortive agents like antacids or alginates. Investigate root cause: hiatal hernia, diet, eating patterns, weight. Prevent progression to Category 1. Category 4, the frail elder with polypharmacy. Action: individualized harm reduction. To prescribe the PPI if possible, but if not, ensure it is truly necessary and at the lowest dose. Prioritize comfort and quality of life. Now, comment your category. Format: Category 1. 12 years on omeprazole, age 70. This self-assessment is power. It's the first step in taking back control. Now, my 7-step safe stomach, safe brain to prescribing protocol. Do not do this alone. Use this as a conversation guide with your doctor. Print it out. Bring it to your appointment. Step 1. The why audit with your doctor. Schedule a dedicated 30-minute appointment. Do not try to do this during a med check. Say, I am concerned about the long-term stroke, kidney, and dementia risks of my PPI. Can we review my medical records together to confirm I absolutely still need it? Do I have an endoscopic diagnosis that mandates it, or was it prescribed empirically for general heartburn? You'd be shocked how many people are on PPIs for no documented necessary reason. Ask, what was my original diagnosis? Is there a recent endoscopy report that shows I still have active esophagitis? If the answer is no, you have a green light to deprescribe. Step 2. The slow strategic taper. The golden rule. This is the master key. Abrupt stoppage equals guaranteed failure and suffering. If you take a pill daily, the protocol is multi-stage. Stage 1. Go to every other day for 2-4 weeks. Your body will notice, but it's manageable. Stage 2. After 2-4 weeks, go to every third day. Take it Monday, skip Tuesday and Wednesday. Take it Thursday, etc. Do this for another 2-4 weeks. Stage 3. Try stopping completely. Alternatively, you can switch to a low-dose H2 blocker, like Pepsid 10 mg, for a month, then taper the H2 blocker. Another method is to open the capsule, if it's a sprinkle type, and remove a few beads each week. But this is tricky and best done with a pharmacist's guidance. The key is slowness. It allows your stomach's acid-producing cells, proton pumps, to wake up gradually without the violent rebound that feels like a heartburn hurricane. Step 3. The magnesium and B12 replenishment plan. Start now. You are likely deficient. Start this during the taper, not after. Do not wait. Magnesium. Use a highly absorbable form that is gentle on the gut. Magnesium glycinate is ideal. Start with 200 mg daily at bedtime. It helps with sleep and muscle cramps. After 2 weeks, increase to 200 mg twice daily if needed. Do not use magnesium oxide. It's poorly absorbed and acts more as a laxative. You want to replenish your tissues, not just clear your bowels. We are aiming to restore vascular and neuromuscular function. Vitamin B12. Use sublingual methylcobalamin. This bypasses the gut absorption problem. 1000, 2000 Mac daily, under the tongue. This will help with energy, nerve function, and cognitive fog. This replenishes your body's armor against vascular and neurological damage. Step 4. The dietary and temporal shift. Non-negotiable. You must change the conditions that caused the reflux. Masking symptoms with a pill allowed bad habits to continue. Now we fix the habits. The 3-hour rule. No food or drink, except small sips of water, within 3 hours of lying down. This is the single most effective lifestyle change for reflux. Gravity is your friend. Meal size. Eat smaller, more frequent meals. An overstuffed stomach increases pressure and drives acid upward. Trigger identification. Keep a detailed food symptom diary for 2 weeks. The usual suspects: coffee, even decaf, alcohol, chocolate, mint, spicy foods, tomatoes, citrus, onions, fatty/fried foods, and carbonated beverages. You don't have to eliminate all forever, but you must identify your triggers. Weight. If you are carrying extra weight, especially abdominal weight, it increases intra-abdominal pressure. Even a 510% reduction in body weight can dramatically improve or eliminate reflux. Step 5. The mechanical intervention. For many seniors, reflux is caused by a hiatal hernia, where part of the stomach slips through the diaphragm into the chest cavity. Diaphragmatic breathing. Practice daily. Lie on your back, place a hand on your belly. Breathe in deeply through your nose, letting your belly rise, not your chest. Exhale slowly through pursed lips. This strengthens the diaphragm and can help pull the stomach down. Posture. Avoid heavy lifting, straining, and bending over at the waist after meals. If you must bend, bend at the knees. Bed elevation. Raise the head of your bed by 6 inches, using sturdy blocks or a wedge under the mattress. Do not just use pillows, as this can kink your abdomen and make reflux worse. Step 6. The safer rescue remedy. Once off PPIs, you will have breakthrough symptoms. This is normal, especially during the taper. Have these on hand: Gaviscon Advance, UK formula, or Gaviscon Extra Strength, US. This contains alginate. When taken after meals and at bedtime, it reacts with stomach acid to form a thick, gel-like raft that floats on top of stomach contents, physically blocking reflux. It's a mechanical barrier, not a systemic drug. This is your new best friend during transition. DGL, deglycyrrhiznated licorice, chewable tablets taken 20 minutes before meals. DGL helps stimulate the stomach's own protective mucus production and soothes the esophageal lining. It's a healing agent, not an acid blocker. Slippery elm bark, a demulcent that coats and soothes irritated tissues. Can be taken as a powder in water or in lozenge form. These are not for daily long-term use forever, but for symptomatic relief during the transition and for occasional flare-ups. Step 7. The confirmation and monitoring. 3 months after successful cessation, get your blood tested. This is for positive reinforcement and to ensure health is restoring. Magnesium RBC. Red blood cell. This is more accurate than serum magnesium for assessing long-term status. Vitamin B12 level. Basic metabolic panel to check kidney function. Creatinine eGFR. Complete blood count, CBC, to check for anemia related to B12. This objective data will show your improvement. Seeing your magnesium level normalize is powerfully motivating and cement your success. It also provides proof to your doctor that deprescribing was the right move. Now, the common questions and fears. Q1. The rebound is terrible. I tried to stop and couldn't. Does that mean I need it forever? No. 1,000 times no. It means you tapered too fast. The rebound is proof of the drug's dependency, not proof of your underlying disease. It's like caffeine withdrawal giving you a headache. It doesn't mean you have a headache disorder. It means your body was dependent on caffeine. Go back to step 2. Taper more slowly. Extend each stage to 6-8 weeks if needed. It can take 3-6 months for some long-term users. Persistence and patience are key. Use the Gaviscon Advance liberally during rebound waves. Q2. I have Barrett's esophagus. My specialist says I must stay on it forever. Are you saying he's wrong? For Barrett's, the risk of esophageal adenocarcinoma from uncontrolled acid is real and significant. I am not saying your gastroenterologist is wrong. I am saying you fall into category 2, necessary user. Your protocol is about risk mitigation, lowest effective dose, maybe even alternating days under supervision, proactive supplementation, and vigilant monitoring. Have a detailed conversation with your GI doctor about the stroke risk studies. Ask, given these new risks, is my dose the absolute minimum needed to keep my Barrett's stable? Can we monitor with more frequent endoscopies to see if I can step down? A good specialist will engage in this shared decision-making. Q3. What about H2 blockers like Pepcid? Are they safe long-term? Safer but not perfectly safe or risk-free. They carry a lower risk profile for stroke, kidney issues, and dementia, but can still cause problems with B12 absorption and have other side effects, headaches, confusion, and some. They are a reasonable bridge during a PPI taper or for very occasional use, e.g., once a week, but should not be viewed as a permanent substitute. The goal remains to address the root cause. If you must use something regularly, an H2 blocker is a less risky choice than a PPI, but it is still a crutch. Q4. Are antacids like Tums safe? Antacids are for occasional, infrequent use. Think after a single spicy meal. Chronic daily use of calcium-based antacids, Tums, can lead to kidney stones, hypercalcemia, and milk alkali syndrome. Magnesium-based ones, like Malox, can cause diarrhea and electrolyte imbalance. They are not a long-term solution. They also do nothing to prevent reflux. They just neutralize acid that has already been secreted. Q5. What if my root cause is a large hiatal hernia? Am I just stuck? While a large symptomatic hernia may require a surgical consultation for a laparoscopic repair, fundoplication, many small to moderate hernias are manageable with the mechanical and dietary interventions in Step 5. Weight loss, if applicable, and core strengthening can make a significant difference. Surgery is a big decision, but for some, it offers a drug-free, permanent solution and eliminates the need for PPIs and their risks. It's a conversation to have with a general surgeon who specializes in foregut surgery. Q6. I'm on a blood thinner like clopidogrel, Plavix. Isn't a PPI protecting my stomach from bleeding? This is a classic and dangerous rationale. While PPIs do reduce the risk of gastric bleeding, the interaction between PPIs, especially omeprazole and esomeprazole, and clopidogrel can make the blood thinner less effective, increasing your risk of the very heart attack or stroke you're trying to prevent. If you must be on a gastroprotective agent while taking a blood thinner, discuss with your doctor about using pantoprazole, which has a weaker interaction, or better yet, H2 blockers like famotidine, which do not interfere with clopidogrel's activation. This is a critical medication management conversation. Let me tell you about success. About Bernard. He was 75, on lansoprazole for 15 years for a sour stomach. He had muscle twitches, was always tired, and his kidney function was beginning to dip. He was terrified of stopping. We followed the 7-step protocol over 5 months. The taper was slow. We used Gaviscon for breakthrough symptoms. We fixed his late-night eating habit and raised his bed. The first month was hard, the second easier. By the 4th month, he was off completely. We replenished his magnesium and B12. At his 6-month check, his energy had returned. The muscle twitches were gone. His kidney function stabilized. His follow-up comment to me was priceless. I thought the pill was keeping me safe. I realize now it was making me old. I feel like I got a piece of my life back. And Eleanor, age 71, on esomeprazole for 8 years, chronic migraines and brain fog. Her neurologist was stumped. We deprived the PPI over 4 months. Her migraine frequency dropped by 70%. The brain fog lifted. It's like a veil has been lifted from my mind, she said. Her migraines were likely linked to the vascular instability and magnesium deficiency caused by the drug. Helen's story is my motivation. Bernard's and Eleanor's stories are your proof. It can be done. You are not doomed to choose between a burning chest and a vulnerable brain. There is a middle path, a path of true management, of understanding root causes, of using medicine wisely and sparingly. You now hold critical knowledge. You understand that proton pump inhibitors are not harmless lifelong companions. You know they can stealthily strip your body of magnesium, stress your kidneys, alter your brain's vascular health, and increase your stroke risk by a staggering margin. You have a detailed 7-step protocol to escape this trap safely and effectively. You know the questions to ask your doctor. You know the symptoms that warn of danger. You have safer alternatives for symptom relief. This information is a shield, but you must raise it. Information without action is just trivia. Here is what you do next. First, within the next week, conduct the why audit. Look at your pills. Schedule that conversation with your doctor. Be the informed patient who drives the appointment. Second, do not stop cold turkey. Ever. Plan your taper. Buy the magnesium glycinate and sublingual B12. Start today. Third, implement the 3-hour rule tonight. It costs nothing and has immediate benefits. Before you go, I need 3 things from you. This is how we build a community that resists silent risks. Subscribe. Click the button. This channel is a fortress against hidden senior health dangers. We uncover the truths buried in fine print and medical journals. Every week we tackle another silent risk: statins, sleep aids, arthritis pills. We go deep with evidence and empathy. You need this community. Share this video privately. Text it to your family group chat. Email it to your siblings. Post it in your senior center's newsletter. This information is too important, too life-altering to keep to yourself. The person you share it with might be on a path to their own Helen-like crisis, completely unaware. You could literally save a brain, a life, a family from grief. Leave your final comment. Choose one. This tells me what step you're taking and shows others they are not alone. Comment "deprescribe" if you are committing to the safe taper protocol with your doctor. Comment "magnesium first" if you are starting with replenishment and the audit. Or comment "for Helen" to honor a life lost to a silent risk and to pledge you will use this knowledge to protect your own health and the health of those you love. Thank you for your courage and attention. Watching this to the end shows you care deeply about your health and your future. You have the power to change your trajectory. Remember, true health is not the absence of symptoms. It's the presence of resilience. It's about building a body that can withstand challenges, not just silencing its alarms with a pill that creates bigger problems. You are the CEO of your health. Your doctor is a consultant. Be an active, informed CEO. I am Dr. Alan Whitman. Stay vigilant, stay informed, and never stop questioning. I'll see you in the next video. Disclaimer: the content in this video is for educational and informational purposes only and is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition. Never disregard professional medical advice or delay in seeking it because of something you have seen in this video. Do not initiate change or stop any medical treatment or medication based on the information presented here. Always consult with your personal physician before making any health